So sure, really what we'd like to cover with you all today, and we really appreciate the time coming to speak with you, is what we have in front of you is our employee benefits market outlook for 2023. We are absolutely halfway through the year, but really what we want to cover today is the state of what healthcare is and what all employers are facing right now. And what you'll see here as we go through the table of contents, we have our executive summary from our national benefits practice leader, covering everything that USI can do as a whole, right? So we are a national brokerage. We are the largest middle market broker in the country and the fastest growing in the Philadelphia region as well. Not only does that, we have a national presence, we have a very regionalized and local expertise. And where I want to focus on, Derek, if we can begin to, is our attack the healthcare gap. Really what this image shows for you all is that the system is broken within healthcare. I think we can all agree that costs, rates, premiums, deductibles are increasing year over year. 10 years ago, you see that the average rate was about $300, and today it's $800. 10 years from now, projecting 2,000 plus. If you're not managing this correctly with the strategic long-term solutions in place, it's volatile and it's hard to sustain from any employer's perspective. Where USI has separated ourselves is that we've invested millions of dollars to bring in-house underwriters, dedicated AI technology and solution engines in place to bring in solutions and roadmaps that have financial impacts to our organization and all of our clients. And where we're speaking to this specifically is that if you're not having the correct consultant in place to really support your organization, it's an uphill battle. And it all starts with challenging the integrity of the rates and the renewals that are handed out by the carriers. The problem with this is many insurance carriers have been dictating this process for 40 plus years. They hand you the renewal, you get a 10+% increase, you go to market, you shave a couple points, and unfortunately that's been the dance for almost half a century now. We've taken a very alternative approach where we're challenging their numbers and making sure that we're getting the correct starting point. And it's not so much just getting that increase and going out to market and shopping it. Our in-house underwriters, which we've hired and again invested that substantial capital to bring them in, they worked for the carriers for 25 plus years. They know where the bodies and the fat is hidden within these renewals. And when they come to the seat and we're across the negotiating table with them, we're saying, all right, why is this a 10% increase here? Well, we have to hit our marks for each. Well, no, our in-house underwriters are showing that this should be a 6. Why are we getting a 10 here? And that's the negotiating power that we come with USI. And with that, I'd like to pass it off to Chuck Maleski.
Good morning, everybody. Last year we were over at the rec center, so I'm sitting in the parking lot over there, so I apologize.
Really?
Thank you. Yeah.
Next year, never know.
Yeah, all right. Well,
Give me that.
I'm in. I'll be there a few days early for that one. So I just want to build off of what Vince was saying, not necessarily to talk about USI and what we do, but what the problem is, right? So if you're looking at that graph, the problem is that in 10 years from now, we're going to be in a lot of trouble because already rates went from $300 to $600, $700, $800 for a single PPO because the carriers are dictating a process to you, to all of us, right? They're dictating it. So that's a monthly single rate on average. And for watered down plans, right? They're not the same plans we had before. Like when my kids were born, 20 some years ago, we paid $5 and they were both high risk pregnancies for the entire pregnancy. Now we would have reached our out of pocket max of $8,000, right? So the plans are watered down, the rates have gone up. So what do we do as consumers? What do we do? So it's time to take the power back from the insurance carriers. There's a number of things that are happening that will allow you to do that. Number one, there's a new carrier coming into the market. And this is really important for all of you to know. So IBC has been the dominant carrier for a very long time in the Philadelphia market, and they continue to be. But there's another Blues plan that is entering the market, and that is Highmark. So Highmark is entering the market as of January 1st, 2024. I had dinner with the president of Highmark last night, and that gentleman said, we're going to be aggressive. We've got all the hospitals, we've got all the doctors, so the same Blues network, but he's saying we're going to be aggressive. So that's interesting, right? That's interesting for all of us because what happened was there was a consolidation that took place. I used to work years ago for Prudential Healthcare. Well, Aetna went out and bought Prudential. Aetna went out and bought NilaCare, which was New York Life. IBC bought Keystone HMO and Delaware Valley HMO, and then there was this huge consolidation with limited players. Now you've got Cigna competing, you've got United, you've got IBC, you've got Aetna, and now you got Highmark. And that's all on a fully insured basis. Highmark told us last night that they are also going to be in the 2 to 99 space. So when I say 2 to 99, right now your option if you're under 50 employees is the IBC age-banded community rates. That's what you've got as a choice. Highmark's coming in and competing in that same space. Aetna, United, and Cigna are not strong in that space right now, unfortunately. Get over 50 employees and they'll compete, but under 50 employees, they just don't compete. Highmark is going to. So look, choice is good. And hearing that a Blues plan that's 5 times the size of IBC is coming in to compete is a good thing for all of us. What else do you do? What else can you look at? There are captives that are out there, which is basically a self-funded purchasing coalition. There are consortiums. Consortiums are people pool together and they buy a product, right? The challenge with some of the consortiums, and I won't mention any names, but the challenge with some of the consortiums is they're not necessarily transparent on the back end. So if, Alan, January 1st, you said, all right, I want to look at that consortium. And next January, you're like, well, Highmark gave us a really competitive offer. I want to leave. The consortiums have penalties to leave. And that's big for you guys to know because they don't show you that. A lot of them don't show you that when you're looking at your options. They don't tell you that, hey, you have a 4-month penalty to leave our consortium. 4-month penalty is basically something called run out or TLO. Terminal liability coverage is what that stands for. But so be careful with the consortiums and make sure you ask the question, if I want to leave next year, is there an exit penalty? Or is there anything that you're not showing me right now? Because this TLO coverage that you purchase is an add-on that they don't show you. And that's for all company sizes, right? So you could be 20 lives and go into the consortium. You could be 10 lives and go into a consortium. I just don't want you to be stuck. Stuck is when you're not able to say, Highmark, IBC, Aetna, Cigna, captives compete for my business. We've not been in a position in this market to have the carriers do that for a really long time. For 20 years, it's been negotiate with IBC, negotiate with Aetna. Cigna wasn't really competitive. United wasn't really competitive. Well, now you guys are going to have options, and I like options. It's better for you. It's better to negotiate if you do what Vince and I do. It's amazing in the last year what has happened. If we go to an Aetna and say, your rates, you gave us an 18% rate increase and we're not going to take that. How willing they are to negotiate. When they weren't as willing to negotiate, significant negotiations, by the way. It's not like we'll take it from 18 to 16. They'll go from like 18 to 8 or 7 because they understand that the competition is increasing in the Philadelphia market. So that's good, right? So there's an update. That's a significant update for all of you. What I would also encourage all of you to do, start asking for your rates earlier. They're required to give them to you 60 days in advance. 60 days kind of pigeonholes many of you into making a decision, right? So 60 days, and then you try to go out to market, you try to get some alternative quotes. Then you got to compare, you got to figure out what you're going to do with contributions. Then you got to run open enrollment. And then you've got to submit all of your information to the insurance carrier. And it's 60 days isn't enough time. So you should ask for 90. And I'm sure for those of you that run open enrollment for your business, you know, if you get an extra 30 days, that's pretty significant, right? It's the carriers are more willing to do this now, and it's time to start pushing back. It's time to start asking them to compete for your business and make them earn your business, as opposed to, well, we're the dominant carrier, we're dictating the process to you. If you don't turn this in by the 15th of the month, then we're not going to have ID cards. Well, if we turn it in on the 17th, you better have ID cards or we're leaving you. There's other carriers that want our business. Finally has happened. That's finally happened in Philadelphia. Thank God it's happened. So it should give all of you as business owners more choice, more flexibility, and hopefully stop what's happening up there, right? 10% trend every year doesn't work. It doesn't work. You get to raise your rates in your business is 10% every single year with a watered down product. We all know the answer to that, right? We all know the answer. But in 10 years, that's what I'm saying. If we don't start, dictating a process to the insurance carriers. So there's a couple other things that we put together in the presentation. And if you guys remember, for those of you that were here last year, this is our market outlook. So it's not a USI commercial. It's intended to give you guys an update on what's happening, in the marketplace and what employers are facing. So we spend a lot of time collecting data. When we collect this data, it's with the intention of doing what we're doing here today, which is to provide you with a market outlook on what employers are facing. So we're still seeing things like supply chain being an issue, although it's not as bad as it was a year and a half ago. Supply chain is still an issue. We're still seeing the rising cost of healthcare, which is what you see here. And here's why, again, you should challenge the rising cost of healthcare. What happened during COVID? Happened with me too. We all stopped going to the doctor unless it was an emergency. Like for a year, people didn't go to the doctor, hospitals, they didn't have surgeries because they didn't want to go inpatient. Well, why was there still 10% trend? People weren't utilizing the healthcare system. Why is there 10% trend during that?
2% as well.
Right, or more. So we talked about this last year, right? So the COVID load that the insurance carriers were applying to the rates, as of May 11th of this year, the public health crisis was over. If any of your renewals include a COVID load, immediately say no way. Some of the carriers are still trying to do it, saying, oh, well, we're not changing that until January. Don't take it. Absolutely, positively, no way. One of the carriers actually had an 11% COVID load every year for 2.5 years. They had an 11%. One of them had 5%. One of them had 3%. There should be no COVID loads in your renewal then. All right. So here are some strategies to reduce the cost of healthcare. So what you see with managed fixed and variable costs, what that's basically saying is that the insurance carriers are dictating to you that, and the Affordable Care Act dictated to you that 85 cents on every dollar has to be used to paying claims. The other 15% is paying for their salaries, to turn the lights on and off, to pay for their margins, right? One of the ways that you attack that is looking at alternative funding. So where it says manage fixed and variable costs, your fixed costs when you're fully insured are that 85% is supposed to be spent on claims, and then the other 15% is overhead and admin. When you go down to alternative funding, like level funding, like a captive, like self-funding, that's where you start to make a dent, because here's what happens. When you go to alternative funding, there is no ACA tax anymore. The Affordable Care Act tax won't exist when you're self-funded. So level funding is something that you pay level premiums for the whole year, and it looks just like you're fully insured, but technically it's filed as a self-funded product. For many of you, you don't get claims experience because you're not large enough to get claims experience. When you're level funded, you get claims experience if you're 15 employees. You get claims data. So that's one way, is looking at these captives, looking at self-funding, looking at level funding. Level funding is a nice kind of middle route because it looks like you're fully insured, but it's filed as a self-funded product. And you have the opportunity to have a surplus at the end of the year if you ran better than they expected. So that's a way where you get rid of your state tax at 2%, you get rid of the ACA tax, and you get rid of carrier risk and margin. There's usually an 8 to 10% delta there right away. So again, I go back to choice, folks. You have choice now, where before it's fully insured and that's it. There are other things that you can do. The one on the bottom, transfer costs through plan design changes, that's a shell game that's been happening for a really long time. We talked about that earlier. What has happened? What's happened is you have to keep watering down your plans because a 10%, 15% rate increase every year, you water down your plans, your rates go, oh, well, now we're down to 7%. We're asking our employees to take on another $1,000 of their deductible. Eventually, you're going to run out of room. You're going to run out of the room to the right. You're going to run out of room with plan designs. So transferring costs through plan design changes, the only things that, I would say we're seeing some popularity around are HRAs and HSAs, if you're familiar with that. Health reimbursement arrangements, and HSA is a health savings account. Health savings account can only be tied to a high deductible plan. HRAs can be tied to any of the fully insured products, and it's a reimbursement that you control. So if you have an advisor that you're using right now, you may want to ask them about HRAs and helping the employees offset. Why? Because one of the other things that we're seeing is there is still a war on talent. Every single one of our clients is telling us it costs. So we saw a study about 2 months ago that said the cost to retain your current employees from this time last year to now is 7% higher on average, 7% higher this year than it was last year to retain talent across all industries. So this was a general study that we saw that Kaiser ran. The cost to acquire talent, 15% higher right now than it was last year. And that's really scary. That 1 year over year, inflation has had that much of an impact where it's impacting your bottom line. So 7% and 15%, maybe it's a little bit different for you, but the fact still exists that it is employees they got spoiled working from home. I run our USI's office in Bluebell with 150 people, right? So I see it every day. They want to, well, it's 2 o'clock in the afternoon on a Friday and my wife's home with the kids, or I got to go pick the kids up from daycare. And does that mean I get to deduct 3 hours from your salary? But people got spoiled working from home. We all did, right? People got used to, well, I got to run to pick up a prescription. I got to run to go get my hair cut. I got a dentist appointment. Well, you're all paying those salaries. So there's people have different expectations than they did 3 years ago. And I see it every day as a leader. And it's impacting our business for sure. And I'm sure it's impacting yours. Go ahead,
Can I ask a quick question before
Please.
I forget it?
Please.
The surplus, I'm still back on that.
Sure.
Are the carriers required to write the check to the company for that surplus, or do they keep that surplus?
So does the carrier keep the surplus? So the carrier is not allowed to keep the entire surplus. So many of the level funded TPAs and carriers will give you 50% of the surplus back, and they'll do that 3 to 4 months after your renewal. There's a strategy behind that. Number one, they want you to renew. So they're going to give you that money after you renew with them. But the other strategy is they're going to say, well, let's say you had a January 1st renewal. we had to give you your renewal November 1st. So we stopped looking at claims in September. So October, November, and December, they're going to come back and they're going to look at the claims and say, are you still running at a surplus after people use their plan October, November, December? So those are the two reasons why they hold on to the surplus. But the surplus can either be a check that they write back to you or that you apply it to future premiums. It's your choice as the employer. Just a little birdie should, tell you this one out loud here. You should look for a TPA that gives you 100% of the surplus. Why do they get to keep 50%?
I thought by statute they had to send all the surplus.
They don't have to, no. No, like Cigna, United. Cigna has a level funded product, Aetna's level funded product is called AFA. They keep 50% of the surplus.
Oh, I moved last year, but the Blues, Blue Cross the last 3 years, it's been saying they sent checks after we left.
But those checks are, if you're getting them from the Blues, Jay, are the MLR rebate checks. So the MLR rebate checks are separate than a dividend in a level or a surplus in a level funded product. They MLR, they are mandated that if they don't spend 85 cents on a dollar across their entire block of business, they have to return some of the money. That is different. And next time I'm out, I'll talk to you guys if you'd like about what you're supposed to do legally with those rebate checks.
Tough part of those checks.
It's, I mean, many times you're getting checks for like $5,000 or $4,000, and now you've got to figure out your portion versus the employee portion, and it's not worth the price for you to cut them a check, right? Or to fund that money. So what can you do? You can do a couple of things. You can say, well, we're going to keep that refund, the MLR rebate check, and we're going to put it towards some kind of wellness fund and, maybe some education that we're going to do around heart health, around walking challenges, hydration challenges. You can do that as long as you say that's what we're doing with those dollars. You can return it to them, which in most cases is a royal pain. Or you can apply it towards future premiums. You can say, we're taking that $5,000 and instead of paying 80% of the single in January, we're going to pay 85% of the single in January because we got this medical loss rebate check. Just be careful. Make sure you put it in writing what you're going to do, just so an employee doesn't come back in March and say, why don't I still get that 85%? We were very clear. We received the rebate check, and here's what we need to do with it. A surplus on the level funded products is, let's say that they predicted that you're going to have $100,000, Jay, in claims this year, and it only is $70,000. So you have a $30,000 surplus. They keep 15, you get 15. But why do they get to keep 15?
So you get that written into the contract?
Yep. You should ask for 100% of the surplus. And by the way, if Cigna doesn't want to do it, then you should say, all right, well, we're going to go to one of the TPAs, third-party administrators out there that will give us your network. So the TPAs will use Cigna's network, but they'll give you 100% of the surplus back. So there are ways to kind of play the game here to make sure that you get your best deal. I have clients that are using the TPAs that are getting $30,000 and $40,000 surplus checks back, and it goes to the bottom line. That's a nice hit, right? When you're fully insured, you don't get that. They don't say, hey, by the way, you guys, your claims ran better than expected. It's just they look at their entire book. IBC, for example, will look at their entire portfolio and say, overall, our book ran at 84%, so we're returning 1% of the premium back. All of the carriers try really, really, really hard to show you that they're at 85%. They try really, really, really hard. So I want to make sure that we keep moving to be respectful of your time. So I'm sure many of you are starting to deal with the issue of leave management. I'm dealing with it right now with 3 or 4 of our people that they feel kind of, it's kind of their right, and it is their right. But why is it challenging? Because it's hard to administer and it's hard to police. So what are we seeing? We're seeing companies going to an FMLA outsourced vendor to manage the process instead of you managing it internally. There's too much risk to take on as an organization because the law keeps changing. So this topic alone, we could spend 45 minutes on because of employees know their rights. So they know the state and federal laws and they're protected by them, but you're also trying to run a business. So what's it like if you're a small business and you lose an employee to leave? It impacts the business, your bottom line for sure. So the biggest takeaway here is that most of the employers that we're working with, small and large now, are outsourcing FMLA because of the risk involved. If you make a mistake, it's just a lot of risk for you to take. It's not expensive either. It's really not a big cost to take on. But there will be more to come on this. And as we provide future updates, I'll let you know as the law changes there. There is a page on solutions, but you'll see on here, the disability, they'll partner with their disability. If you have disability, partner with your disability carrier and they will manage leave. There's also third-party absence management vendors that you can go to, and we're happy to help you with it. Let's talk about the next one here, which is voluntary benefits. So many people are saying, have said in the past, like, there's so much taken out of my paycheck right now, I don't want to talk about anything else. Right? It's just too expensive. Medical's so expensive. However, there are some things that have happened in the voluntary market, the voluntary benefits market, that's employee paid, not employer paid, but employee paid, that may be worth looking at. Some of the critical illness and accident benefits that are out there, what they will do is they will help offset some of the cost of deductibles and out-of-pocket maxes. And again, this is employee paid, right? So it may be worth you taking a look at. It's also gotten, believe it or not, it's gotten more difficult on your own to get life insurance that's affordable. So if you say, I want to protect my family, and you go out and get a term life policy, these policies are, after COVID, 15 to 20% higher than they were before. But if you can get supplemental life insurance on a voluntary basis that you can offer through your company, and it's at a group rate, not at an individual rate, you're not paying for it, the employees are, and they can buy, in many cases, up to $500,000 to $1 million. So something else for you to keep in mind, a lot of employers are doing this. I mean, we're seeing employers now saying, because medical has gotten so expensive, dental is now voluntary. Dental used to be a core benefit, right? Yeah, we pay 80% for dental, we pay 80% for medical, we pay 60%. Many employers saying dental's voluntary now. We're going to give you medical and group life because disability's gotten too expensive too. So we'll make STD and LTD available on a voluntary basis. So there's been that paradigm shift of employers looking to take some of the benefits that are costing them some dollars and shifting that to the employees. So the other thing that it does is it lets employees know that you're not just, hey, we have medical, right? So we talked about the war on talent. Well, I've seen this too, interviewing people that come work at USI, I've seen this, where employees are asking, so what's the benefits package look like? Before I make my decision, I need to know what it looks like. As opposed to, yes, I'll take the job, and whatever the benefits are, they are. Now they're looking at them up front. So the war on talent is real. We're seeing it. I'm sure all of you are seeing it. I saw some heads nodding when we talked about it. It's real. And it's real because inflation's hurting all of us, right? When we go to, I went to Giant the other day, and my wife asked me to run to Giant, and I got like 5 things. It was $92. I'm like, I didn't get anything, right? But I got $92 later. I hardly got anything. So inflation's hurting everybody, it's hurting your businesses for sure. All right, so there's one more thing I want to talk about. And that is around your pharmacy program with your benefits. So there are some new medications that are coming out that should scare all of you, because these medications cost $400,000, $500,000, $1 million, these gene therapy drugs. And your medical plan is going to blow up if one of your employees go on these coverages. It's going to blow up. Imagine if you pay $400,000 a year to IBC or to any carrier for health insurance, and then one of your employees or their dependents take a drug that's $800,000. Then what happens? So what can you do to manage this specialty drug cost? So let me just talk about specialty drugs for a second. So before, after the gene therapy, which we just need to keep an eye on, because many of these haven't hit market yet, but when they do, we've got to talk about alternative ways for you to get those medications where you're not paying patent rates. You're not paying $800,000. How do you go right to the manufacturer and then tell them we can't afford $800,000, and then they give you coupons? And so there are ways around that, but you need to be savvy about it. Okay, and keep an eye on this type of data, this type of impact that it could have on your health plan. So most of you are fully insured, correct? You're fully insured with Aetna, Cigna, IBC, United, one of those carriers. Are you aware that we all see the medications that are advertised on TV, right? The catchy little jingles, the Ozempic one that you get stuck in your head all day, right? That stupid jingle. Specialty medications are drugs that are under patent, that they're paying a lot of marketing and advertising dollars for to get you and your doctors to write those scripts. There is a hepatitis C drug right now out there called Harvoni. Harvoni is a $90,000 drug that impacts you. $90,000, but it has a 99% cure rate. It's a fantastic medication. There's a rebate on that medication. Rebate means that it goes from the drug manufacturer right to IBC, right to Cigna, right to Aetna, right to any insurance carrier. It goes right back to them. And the rebate on Harvoni is $50,000. So it's really a $40,000 drug. It's not a $90,000 drug because the carrier gets to keep the rebate. Folks, when you're negotiating with the insurance carriers your renewal, ask them how much money they got in rebates on your prescription plan. Ask them.
My husband just went through that with this. He's demanding them.
You should. They're not in the fully insured world. They're going to tell you we don't have to tell you that. Going back to that first slide, you got to take the power back, at least some of it. Why do they get to keep a $50,000 rebate, yet they're asking you for a 10% rate increase? They got $50,000 back on one drug. There's another medication, specialty medication out there called Duexis. You may have heard of Duexis. Duexis is $3,000 a month, and it's Pepcid and ibuprofen. You can go to Costco and buy 500 pills for $20. But Duexis is ibuprofen and Pepcid in one pill. But it cost you $3,000, and the rebate on that is $1,000. When you're fully insured, the insurance carriers keep all the rebates. When you're self-funded, you get them. When you're level funded, you get them. That's why we're trying to say, be savvy, be an educated consumer. At the very least, if you like fully insured, you like that risk, I totally get it. But ask the question, how much money did you make in rebates last year before you asked me for a 10 or 11 or 12% increase? It would scare you to see how much money they're making in rebates. So the tip here is make sure you ask the question. You're all fully insured, ask the question. how much money in rebates did you guys get this past year? Because you're asking for a 12% increase. Ask them. If you take anything out of this entire conversation, ask them that question. How many of you are advertising or communicating to your employees to use GoodRx? You should. GoodRx doesn't cost you anything. You just go to your employees and say, download this app. And every time that you get a prescription filled, put the prescription in the app and see how much it costs at 5 different pharmacies. So the app will actually give you the names of 5 pharmacies and what the retail cost of the medication is. With the way the plans are now, 40% of the time it's cheaper than using your health plan. So I'll give you an example. My wife had to be on Protonix, which is like an acid reflux medication. They did a, whatever that scope is that they go down your throat to look at the, yep. So they did that scope, and they ended up, when they took the tube out and actually rubbed against her esophagus or stomach lining or whatever, and Protonix helped keep the acid level down, and it helped her gut heal. She had to be on it for 4 months. Our copay at USI for that medication was $125 a month. We have 10,000 employees. Our benefits are similar to you guys, right? It's not like, oh, well, we have 10,000 employees, we have way better benefits. It was $125 copay for this medication. So I told my wife, put it in GoodRx. Wait to hear what the cost was. $19 a month.
Where?
Rite Aid was $19. Walgreens was $19.80. CVS was $21. So I went to Rite Aid and I got the Protonix, and I didn't use the health plan. And I just walked in, I put the app, and I was like, I'm using GoodRx. So I gave that to them, and they were like, all right, they scanned it, and they were like $19. So 2 things happened. Not only did I save $106 a month for 4 months, I also didn't run it through my health plan. So guess what that does for all of you? Less money in claims. So you should be advertising GoodRx to your employees. If you want, I could send Derek a 1-pager on it. Doesn't have USI's logo all over it. So it's not a commercial. This is not a USI resource, but why wouldn't you do that? If you're going to get amoxicillin costs $2. If you're getting prednisone costs $2. Don't use GoodRx for that. But if you have any type of specialty medication, anything where the copay is $60 for the medication, put it in GoodRx. If you have a deductible first, or your prescription copays kick in, look at GoodRx. You should encourage your employees to do it. My own personal example is I saved $106 a month. A month. So think about the markup on that medication. How's GoodRx able to do it for $19, and the retail cost of the medication was $19, but they charged me $125 copay. Holy Lord. Is that like, was that 600, 700% markup? That's what's wrong with the pharmacy world right now. There's medications that you get over the counter that they're charging you $3,000, $5,000, $7,000 a month for, that impact your bottom line. So, so there's been a lot that has happened over the last year since we talked last. Maybe the most significant is there's going to be more competition coming into the market. Another fully insured carrier. Highmark's going to also do level funding. So you'll be able to get level funded quotes from them, and they will do 2 employees and up. So that's important to make a note of. Know that when you're dealing with the insurance carriers, it's time to start taking the power back. Start asking for your renewals earlier. Start asking them how much money did they make in rebates this past year. Negotiate. They've never been more willing to negotiate than right now. Many of you have January renewals coming up. If you have a January renewal coming up, ask for it early, and you should ask for it now. I need it by October 1st now. Don't wait until September, because they're going to say, sorry, you're already on the release date for November 1st. So you should ask them for it now. Say, we need our renewal for budgetary reasons. All you need to do, send them an email, send it through your broker. If you have a broker, send it through your broker, but just tell them, we want a renewal now. Start using GoodRx. Start challenging the integrity of the renewals, right? Because I think, Vince, I heard you say this. We hired Aetna's head underwriter, it was at Aetna for 22 years. He now works at USI. And he told me that even if a company was running way better than that 85% loss ratio that we talked about with the ACA, we still were told give a 15% increase, knowing that we're going to have to negotiate on.
Should have a mind spot.
What's wrong with that? That's that first slide that we showed. That's where we've been conditioned to say, well, if we got the 15 down to an 8, that's really good. So we'll just take the 8 and we'll change our plan design a little bit. That's what we've been conditioned to do. So that's because they've dictated the process. It's time to reverse the script. And that narrative is one in which you guys should be telling them or taking the approach that they're lucky to have you as their client, not the other way around. Otherwise, in 10 years from now, single rates are going to be $2,000, $2,100 for really bad ones. Not sustainable. So competition is good. COVID loads should not exist anymore. Don't take them. But if they are in there, ask the question, is there a COVID load in our renewal? Don't take it. Doesn't exist anymore. You should be using GoodRx. You should be asking about the rebates. Overall, what I would say is that some of these changes, some of these developments are a good thing. There's plans now that give you more information. You're supposed to, I'll leave you with this thought. When an insurance carrier comes to you and says, we need a 20% rate increase, who projected those rates the year before for them? They did. So now you need a 20% increase, and I'm supposed to trust you on that 20% rate increase when you're the one who told me those rates would be good. So there's the problem. The problem is that they have these formulas. They plug those formulas in, and they want you to trust us. $300 to $700 or $800 is where trusting them has gotten us in the last 10 years. The insurance carriers are our partners. We need them. All of us do. But on your terms, not theirs. So if there is a theme for today, it's on your terms, not theirs anymore. There's choice. You got 5 major insurance carriers as of January 1st that are going to be in the Philadelphia market. You've got multiple level funded carriers. There are 8 to 10 level funded carriers that will give you quotes. There's self-funding. There are captives. There's so much choice now that you're not boxed in. So we appreciate the opportunity, as always, to come in here and talk to you folks. Derek, thanks for all your help. It's tremendous help this last couple of weeks. We really appreciate it. Any questions for us?
Is there any risk if you go to a level funded or self-funded and you want to try to go back to one of the major carriers, is there any risk there in terms of not having the availability of the claims experience or that kind of thing where they kind of treat you like, you got to come in here because we don't know what your group's like?
Yep. So Jay, it's a great question. Number one, if you are level funded, here's what a lot of people don't know. When you're fully insured, you have stop loss. I don't know if you know what stop loss is, but stop loss is basically if you have Aetna and Aetna says the first $50,000 for claims is going to be on us. And after that, we have protection. So they call it, when you're fully insured, they call it pooling. It's a pooling charge that's part of your rate. When you're level funded, it's called stop loss. When you're self-funded, it's called stop loss. You have to have the right stop loss contract, Jay, to protect you. So level funding, your stop loss contract in 98% of the cases will say if January 1st of the following year, Jay, you want to get out because you didn't like level funding, you can. Because they all have stop loss contracts that allow for that run out. When you're purely self-funded, you want to have something called a tail or run out coverage. And this is getting maybe I'm getting too far in the weeds, but
We have that when the practices.
yeah, exactly right. So it's the same thing, same concept, but the insurance carriers look at your claims as you incur a claim, and then when do they pay a claim? So Abington Hospital may not submit your claim for 2 months. And if you end your coverage January 1st and December 28th, you went to the hospital, that claim isn't going to be paid before you're no longer their client. So you have to have what they call run-out protection that will protect you for January, February, and March for any claims that were incurred before you left, when you're self-funded. The level-funded carriers already have that protection, Jay, so there is no risk there. The risk becomes when you're purely self-funded to have the right stop-loss contract. So you usually want, they call it like a 12-15. It's incurred in the 12 months, but it will be paid over 15 months or 18 months. You want that kind of contract. Just make sure you have, with the easy answer, Jay, is make sure you have run out or tail protection on the back end on any of those type of alternative funding plans. Ask about the surplus too. Why do they get to keep the surplus? Why do they get to keep 50% of the surplus? For what reason? They're already keeping your rebates. Why do they get to keep the surplus too? You're already paying them a premium to access their network and for them to pay your claims. So why do they get to keep the surplus and the rebates? So one really important thing happens when you are level funded. You start getting your claims experience. On a monthly basis, you start getting your claims. Even if you're 20 employees, you start getting your claims data. If you're 60 employees right now with any of the insurance carriers, they tell you under 100 employees, we don't have to give you your claims experience. But trust us, we have your best interest at heart. Not so much. I don't trust, right? I just don't, because I look at where it's gotten us. So what I would tell you is that it's time to take the power back. It's time to be a savvy customer and know that there are options. And none of the options are really catastrophic. There's another product out there called reference-based pricing. What I would tell you there is be careful. Some employers who just are looking at the bottom line have moved to reference-based pricing, but it's really popular in California and out west. We know that's a different country and all in itself, right? California. But reference-based pricing basically suspends your hospital claims and they try to negotiate with the hospital a better deal. So if there's a $100,000 hospital claim, the average discount on hospital, 57, 58%. So let's say that Abington Hospital, you go for a $100,000 claim and your carrier pays them $43,000 for that bill. With reference-based pricing, they don't pay the $43,000. They suspend it. And then they call and try to negotiate with Abington and say, will you take $20,000? And then the claim, and if Abington says no, the claim is suspended, it's suspended, it's suspended, your employee starts getting, your employees could get notices at their home saying that you're going to go into collections because we haven't gotten paid yet. Now, reference-based pricing is priced about 20% below fully insured rates. But there's a reason. You want your employees really angry, especially when there's a war on talent right now. I'm not saying that it may not be a good negotiating tool. That you get a price on reference-based pricing and then go back to your insurance carrier and say, hey, look, we have a rate here of 20% below and you need to negotiate. So that may be an opportunity for you to at least get a quote. I would tell you that moving to something like reference-based pricing requires a lot of education for your employees, a lot of education. So there are options, folks. There are options. It's always good to see you all. And again, thank you for the opportunity. I'll leave some of my cards on the table. If you ever want to pick our brains on anything, we're happy to do that for you. There's no pressure. This is more of an information session, and I appreciate everyone always inviting me here every year, Alan. So thank you for that. So if there's no other questions, we'll let you get back to the business at hand, but we always appreciate the opportunity, and like I said, I'll leave some cards and extra presentations on the table. If you need anything, don't hesitate to give us a shout.
Thank you.
Enjoy the rest of your summer, everybody.
Thank you.